This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Dealing with intraoperative surprises can be challenging. This is one such case where I had an intraoperative iris prolapse from the beginning of the surgery, and let's see how things turn out. She's a 75-year-old lady who has pseudoexfoliation and a moderately dilating pupil, a nucleus which is around grade 2 to grade 3. Surgery is begun by giving about 1.5 ml of posterior subcutaneous anesthesia, and I'm not expecting anything very unusual. I plan to use the BX device in this patient. She's just on one antihypertensive drug. It's a calcium channel blocker. The 2 side ports are made. Everything looks to be fine, and I inject air bubble. As I'm trying to inject trypan blue, I suddenly feel that the AC shallows and the iris just tries to come out. So I somehow put in a little bit of dye, but it was very difficult for me to introduce the cannula inside. The AC was shallowing and there is no space for me. So this got me thinking that this is something unusual which is happening here. The first thing which I go ahead and do is check the pressure of the eye, whether the pressure is very high. No, the eye was very soft. It's not an issue. So maybe I thought I'll try from the other side port. Again, the same thing. The AC collapses, there's no space, and the iris is trying to come out. Now, as I'm trying to wash out the dye, I can see that the cannula is in fact rubbing against the stroma of the iris and is at risk of perforating the stroma of the iris. And the visibility is not great, the chamber is shallow, and as the visibility clears off, I can see that there is a small amount of stromal tear here. So lack of space and the propensity of the iris to come out was very much unique for this patient. As I'm stabilizing the eye with my second instrument to perform the main incision, the iris from the left side port just tries to sneak out. Now, if the iris starts to come out through the wounds at the beginning of a surgery, well, that's really something which is quite irritating and can be bothersome later on. I'm just trying to negotiate the iris back in, and I'm using a little bit of a dispersive OD to ensure that it stays put. The iris again tries to come out. At this point, again, I just want to confirm that I'm not dealing with an intraoperative hard eye. I go in and check the pressure. It looks fine. Using a Sinskey hook through the main incision, I just go in and tap the iris down a little bit, reducing some of the pressure which was from behind, that is from the OVD which is let out. Nevertheless, my diagnosis as of now seems to be a floppy iris syndrome and not an intraoperative hard eye case. The iris looks to be very thin, elastic, and has a great propensity to just pour out through any of the openings. And the more we touch the iris, the more thinner it's going to be and the more reactive it's going to be. And then it would try to pour into all the incisions. So the situation is quite tricky. The surgery is just begun. I have not even put in the BX device. The AC is shallowing and the iris is trying to come out. Now this is some situation to be in. Again, I refill the chamber with just a little bit of OVD. This is a dispersive OVD with sodium hyaluronate and chondroitin sulfate. The key is not to overfill. Anything goes behind the iris, more OVD, the likelihood of the iris to just pour out of the incisions. So we need to be very mindful of this aspect. The BX device is introduced into the antechamber above the surface of the iris. The globe is stabilized with my second instrument. It's the Banaji's eye lock. And thankfully, all the notches of the BX device could be placed in quite easily. Not an issue with that. Since now I have not stretched the pupil, the mydriasis is not great at present, but I'm trying to stretch the pupil with the BX on itself, hoping that it'll dilate a little bit better. As I try to puncture the capsule for rhexis, I can see that the entire bag is moving, suggesting of possible generalized zonular weakness. In these eyes with pseudoexfoliations, I prefer to make a slightly bigger rhexis. The flap is folded and I'm trying to tear in much beyond the pupillary margin so that the rhexis margin is quite big. As the rhexis is being completed, in the subincisional area, I feel that it is extending towards the equator. I stop, put in more OVD and use a micro forceps from my side port and then pull the capsule back in. Looks to be alright. But during all these maneuvers, the iris is again peeped out through the left side port. So whenever we have a situation where the iris just is sneaking out and it's almost behaving like it's not going to be replaced back into the eye, it's better not to touch the iris at that time. because the more we try to reposit it, the more it will try to come out. So the principle which I follow is just leave it there and then continue with the surgery. Because the wound is small, it's unlikely to cause any major chamber instability during phacoemulsification. So I'm just going to leave it there. The hydrodissection is done. The nucleus is rotated. Time to perform the phacoemulsification. The chopper is gently introduced over the surface of the iris and gets into the eye. Nucleus management is not going to be difficult in this case. This is a relatively soft cataract. It's about grade 2+. The direct vertical chop is being performed. The nucleus is divided into smaller fragments. The important thing is to ensure that the plane of emulsification is much more anterior than the usual levels. Usually I recommend the nucleus to be emulsified at the level of the rexus or at the level of the iris. But in this case, it's mandatory that we pull the fragments out of the bag into the antechamber and then emulsify above the plane of the iris. This ensures that the fluid does not go behind the iris and push it out again. So this is one difference when we are emulsifying the nuclear fragments in eyes who have these floppy iris. The second important modification which I have done is the bottle height is slightly reduced. So usually we have a bottle height of about say 95 to 100 centimeters. In this case I would bring it down to 80 and reduce my parameters accordingly so that we don't have any compromise in the antechamber stability. Once the lens is out, the iris goes back and the chamber is deepened. You can see that when I'm trying to do the bimanual I&A, the iris seems to be put in and is not coming out. At the same time, in eyes with these pseudoexfoliation and suspected generalized zonular weakness, there's always a risk of fluid misdirection happening and then a positive pressure developing again. And thankfully, that scenario has not yet started in this eye as of now. Time to place the lens. The capsular bag is filled with OVD and the planned single-piece lens is maneuvered gently into the eye. The notches of the BX device are disengaged and the ring is removed out. Thankfully, the case went off pretty well in spite of all the initial jitters, and it was quite stressful to see the iris in the beginning. And these are the post-op pictures, and of course we have areas of iris atrophy. One part which is trying to come out through the side port and the other part was the initial trauma when you're trying to reduce BSS to wash out the dye. Thankfully, the patient did not have any symptoms suggestive of dysphotopsia and she was quite happy. So to lessons learned from this case is, floppy iris can happen in women as well. So they don't have to be men who are taking anti-prostate medicines. So it's important to distinguish an iris which is prolapsing out from other eyes which are causing intraoperative eye syndrome. So in floppy iris, the eye will not be hard. It's only the iris which is trying to pour out, because it is thin and it has a great propensity to just pour out of the incisions. On the contrary, in intraoperative eye, apart from the iris having a tendency to prolapse out, the eye would be very hard with progressive shallowing of the antechamber. So that would be the key difference. So you need to be pretty sure whether we're dealing with intraoperative hard eye or just a floppy iris syndrome. In case of a floppy iris syndrome, and after a couple of attempts, if the iris is refusing to go out, especially if it is mild as in this case, when it is prolapsing to just one side port incision, you can just leave it until you remove all the nucleus. Trying to push back the iris is going to cause more trauma and the propensity to prolapse will increase. So best would be just to leave it there and then complete the procedure. And as we saw in this case, once the nucleus was emulsified, the chamber deepened and the iris fell back to its original place. So these are some of the key points which I learned from this case. I hope you found it useful. Thank you for watching.